Good afternoon, everyone. I'm Dr. Blair Holladay, CEO of the American Society for Clinical Pathology. Welcome to our 13th ASCP Town Hall with a very notable guest joining us today. At the beginning of this year, news reports of a novel virus, SARS-CoV-2, were flooding throughout the airwaves. The virus was sweeping throughout China, making its way towards Europe, other parts of the globe. It became a fast-growing concern for the world to take on at large. And on January 29th, the president announced the formation of Coronavirus Task Force, charging them with leading our government's response to COVID-19 and leading the efforts to monitor, contain, and mitigate the spread of the virus. Since its inception, Dr. Anthony Fauci, director of the National Institutes of Allergy and Infectious Disease, became the face, the scientific voice of reason, navigating us through this pandemic, appearing and speaking almost daily at briefings about the U.S. progress towards fighting COVID-19, including just a few hours ago, where he provided a critical testimony to Congress. We're very honored to have him today to have a fireside chat with us. Dr. Fauci, welcome.
Thank you very much. It's really a pleasure to be with you, Dr. Holladay. Thank you for having me.
Before we get started, we're going to pause just a moment to make sure we can share our CME faculty disclosures for the town hall. Okay, so let's get straight to the heart of the matter. Dr. Fauci, again, thank you so much for joining us and appreciate you making a way across town from the congressional testimony to have your dialogue with us today. We are thrilled to have you. And let's just jump right into a question that all of us have been thinking about. I want you to walk us back to the beginning of this year. Walk us through the days of SARS-CoV-2 before it was even diagnosed in the United States. And what was going on? What was going through your mind? And do you think as a country at the time, do you feel like we were ready for it to spread the way it did through this country?
Well, you know, it's really very interesting that we had, as a country, which is multiple agencies, NIH, as you well know, is responsible for the basic and clinical research for the development of understanding of disease and the development of countermeasures like diagnostics, therapeutic, and vaccines. And there's the CDC, and then there's BARDA, the Biomedical Advanced Research Authority, that essentially purchases and finances companies to take risks to make products that we would need for an outbreak, but may not be necessarily something that's a blockbuster drug for a company. And we have the FDA, and we have a number of agencies. If you put them all together and look at our pandemic preparedness plan, antedating this by years, was judged, you know, by Johns Hopkins University, as being the best pandemic preparedness plan of any country in the world. And yet, interestingly, we got hit worse than anybody else in the world, which tells you that, you know, you can never be absolutely prepared for aspects of an emerging infection that in real time, you're learning just exactly what it is. And really from those very first days, although we had plans in place, things did not work right well at all in the beginning. I think particularly in the thing that's most notorious was in the early days, our lack of ability to get a good testing program going. That was the first thing. And it took a long time before we had not only the tests, but the capability of effectively identifying, isolating, and contact tracing. So that was something that everyone recognizes now as a misstep. The other thing was the lack of appreciation, and we really had no way of appreciating it until it sort of became obvious that we were dealing with a disease in which there clearly was community spread. I mean, in the beginning, the Chinese had mentioned that this was almost certainly mostly an animal to human spread and not human to human. And then they said, well, it can go from human to human, but pretty inefficiently, sort of like the original SARS from 2002. And then as the weeks went by and we had the first case or two here, the question was, could it or could it not be spread efficiently? And then we found out as the weeks and months go by, and that's really one of the problems with this responding to an outbreak like this. In real time, you're learning more and more things. And we learned, first of all, that it's extraordinarily efficient in spreading from person to person, completely unlike what was originally thought, that it went from animal to human and maybe human to human and human to human, not so good. But then all of a sudden, it clearly is almost unprecedented in its ability to spread from human to human. Then the other thing we found out is that a substantial proportion of the people are without symptoms, and that people without symptoms can spread the infection, which makes the already marginal capability in the beginning of doing testing, isolation, and contact tracing made it that much more difficult. So bottom line is we got hit really badly. We're a big country, we're heterogeneous, and we did not have a unified, homogeneous response. We had 50 separate states, some of whom did things appropriately and correctly, some of whom tried to do it appropriately and correctly, but the citizens of their country really didn't pay much attention, maybe didn't believe that this was something that could really cause a considerable degree of a problem because it's so heterogeneous in its manifestations, from essentially no symptoms to being able to kill people with a high degree of morbidity and mortality, and susceptibles like the elderly and those with underlying conditions. So it was a process that was an evolving process. And right now we're in a situation where, as you well know, we have 200,000 deaths and just short of 7 million infections.
Well, it's a debilitating number to think about, but I want to talk a little bit more about what you just said in terms of the potential for an unrecognized strategic imperative for us to coordinate our response. And as you know, in the laboratory, we have been working vociferously around the clock 24/7 since this pandemic began to develop the appropriate assays to look for obviously a diagnostic DNA assay. And then as these EUAs rolled out over the course of the last 7 months, there's 133 out there now. We obviously don't want to run 133 tests in the laboratory. We want to make sure that we can keep our quality control, et cetera. But we'd like to talk a little bit about this national testing strategy, because in the beginning, ASCP and its colleagues looked very carefully at a strong push for a national testing strategy. In your opinion, why wasn't one implemented more immediately?
Yeah, that's a good question, Dr. Holladay. And, I cannot figure out what you would call an acceptable answer to that. Because when you ask, people will say, well, we do have a national strategy. But, in many respects, when you look at how the different states are doing things differently, the thing I keep bumping into when I try to explain to people who are not involved in this why there are so many difficulties and apparent inconsistencies is that we have a large country of 50 separate states. And one of the beauties of the country, and dating back to the founding fathers and federalism, is that you have a central government. But when you're talking about things that are going on locally, the states have the right essentially to do what it is they feel they want to do for their own state. That could work well in a variety of other situations that I don't understand very well, economic, transportation, things like that. But what happens is that when you get an infectious disease, a highly transmissible infectious disease, boy, that's the great equalizer among states. So if ever there was a situation where you would want people to do things in a uniform, consistent way, which in essence would be a national as opposed to a state by state plan, a pandemic is one of those situations. And I don't think that that was necessarily appreciated. You know, and it isn't as if they did things wrong, they just did things differently. And when one state, for example, would, when we got to the point, which I'm sure you remember very well, when we got to the point where we wanted to start reopening America again, because you can't shut down the country indefinitely. It's not only detrimental to the economy, but it can even have unintended negative health consequences for people to do that. There was varying degrees about how the states approached that. I mean, we put together a real clear guideline. You know, you had a checkpoint in the beginning, and then you go to phase 1, phase 2, phase 3, and the variability with which states accepted that, implemented that, and even those states that try to do it correctly, many of the people in the state or in the city, you would see on television at night, people congregating at bars with no masks, when the guideline explicitly tells you what you need to do. So that really turned out to be a significant problem. The other issue that I think is important is that when you shut down in order to do the physical distancing and to cut down the transmissibility purely by separating the people from the virus, is that we did that to varying degrees. If you look at the European countries, and certainly the Asian countries, when they shut down, they really shut down. You know, I have a series of slides in a lecture of showing when you track people to see what their movement is, did they really shelter in place? Well, we sheltered in place much, much less than many countries in Europe, and certainly less than countries in Asia. So our baseline never went down to a really low level. If you look at the charts that everybody sees right now, because you could access them, we had a peak. And when we started to come down, instead of coming down to a really low level, the way the countries in Asia and the way the countries in the European Union did, we plateaued at around 20,000 cases a day. And then when we started to, quote, open up the economy and open up the country, that it went up because people did it variably. It went up to 70,000 a day, which is, you know, to put it mildly, is unacceptably high. So right now we're down to around 40,000 new cases a day. Now, the thing about this that is disturbing is that as we enter the fall and the winter, and people will be doing things indoors more than outdoors, we could have a problem unless we get that baseline really, really low. And I think we have a few weeks to a month to do that. And that's the reason why at every opportunity I plead with the American public that it's going to be important to do the simple guidelines: wear a mask, physical distance, avoid crowds, outdoors more than indoors, washing hands frequently. Those things sound almost simplistic because they're so easy to do. And you don't have to shut down the country to do that. You can gradually and prudently and carefully open up the economy while still implementing those public health measures.
Well, it's a good point you were making about, I'm just going to paraphrase here, the lack of vigilance maybe by American citizens compared to how this was clearly marginalized much more rapidly in other countries. And we don't want to talk about the culture, but of course, you know, there's folks out there that still say it's a hoax. How do you deal with people and the conversations around, is this just a hoax? Is it real? It's only infecting less than 1% of the population, and yet, you know, it's drastically affected the economy. What is your response to that?
it's dumbfounded. I was trying to think of the right word. That's the best one that came. How can you say something's a hoax when you have 200,000 deaths over a few month period and almost 7 million cases? When you look at us versus the rest of the world, you know, we have what, 4 to 5% of the population of the world, and we, you know, have something like 20% or so of the deaths. It's really, really painful when you hear people talk about hoaxes and talk about not needing to do any of the public health measures. And also, you know, something that is unfortunate, but it's something we have to deal with. There's a great deal of divisiveness in the country. I mean, that's not my opinion. You just need to look at what's going on today. And you could see that. Take a look at the, you alluded to the congressional hearing that I testified at today. Just, you know, take a look at the hearing and the differences on either side of the aisle about things. When you have a public health issue that should transcend completely any kind of divisiveness, because we all are in this together. This is a problem for the country, not a problem for one particular group. It's a problem for the whole country.
Right. This is not a country of red states and blue states, is it? This is the United States of America, and diseases don't respect, you know, geographic borders or political persuasions, clearly. And I think that's a very good point you're making. You know, whenever we've discussed this before on town halls, but when folks are naysayers and they're out there discussing why is this really going to affect me? Is this truly as significant as it's being made out to be? Is this more politicized? Our response has always been, and one response I gave recently was that, well, it's a hoax until you hug your grandparents and they catch this disease and pass away from it. Then you'll see how important it was. It's a hoax, you know, when your grandchildren are unable to give you a hug because of the fact that you aren't following the appropriate public policy. So again, thank you for being a warrior through this conversation about, you know, the perception by our citizens, because we do have to be conscious of the fact that diseases don't have eyes and ears and we can't see them. We have to be conscious of the fact that we know they're there and we have to trust the scientists and we have to listen to them.
Yeah, one of the things, Dr. Holladay, that confounds the message is that of all the viruses and outbreaks that I've had to deal with, you know, over the last 36 years that I've been the director of the Infectious Disease Institute, I've never really seen a virus that has such a broad range of manifestations where a certain segment of the population, even when they get infected, very rarely have symptoms, or if they do, they're generally mild. And you look at the data, that's young people. So you could understand, and I say that they do it inadvertently, and I would use the word innocently because I don't want to be pejorative or put blame, that a lot of young people say, well, look, I can see that the data say that if I get infected, the chances are very good that I will get minimal impact, either no symptoms or only minor symptoms. Well, there are two things about that are misplaced judgment. And that is, first of all, some young people do get seriously ill. Not a lot, but some do. Number two, we don't know yet the full long-range effects of what it means to get infected. There are some interesting studies coming out now about subclinical cardiology problems where people have inflammatory responses of the heart as shown by MRI, people who recover completely virologically and are essentially asymptomatic. So one, you have a responsibility to yourself. But as important, in my mind, is that if you get infected, and as you correctly said, if you get infected, even if you're without symptoms, you can't consider yourself to be in a vacuum because you are propagating the outbreak. because it is conceivable, if not likely, that you will inadvertently and innocently infect someone else, who might then go on to infect someone else who might be, as you said, someone's parent who's an elderly, someone's grandparent who has an underlying condition, a young child with an immunodeficiency, a woman in the middle age on chemotherapy for breast cancer. There are so many people who are actually vulnerable to the serious effects of this. And to say it doesn't matter if I get infected because it's likely I'm not going to get a deleterious consequence, I think is quite frankly relinquishing your responsibility to society by doing that.
Well said. I want to point out a piece of literature that was published about 13 some odd years ago. Since you're a scientist, I know you'll appreciate this. There was a publication in Clinical Microbiology Reviews. And this actually is a question that was submitted by one of our members, Jeffrey Schrager, who's a hematopathologist. And he said that, you know, the presence of large reservoirs of SARS-CoV-like viruses in horseshoe bats, together with the culture of eating exotic animals in southern China, is a time bomb. This was actually the quote from the actual article. And here we are 13 years later dealing with a way to mitigate this. And as you know, over the past decade, or at least 20 years, we've had SARS, MERS, now we've got SARS-CoV-2. It just seems like there is maybe more of a need for us to look at these zoonotic outbreaks in the first place. And so what preventive measures do you think what might look like after we accomplish victory in defeating this virus? What kinds of roles do you believe in public health will be necessary to prevent these future types of zoonotic outbreaks?
You know, that's a great question, but what it is going to require is global multinational cooperation. Because if a few enlightened countries see exactly what you're saying, there's a number to that. About 70 to 75% of all new infections, namely emerging infections that are new, are zoonotic. Namely, they jump species from an animal host to which it probably, over a period of evolution, has adapted itself to the animal host. And yet, when it gets into another host, it can cause a devastating disease and be transmissible. It is so much to do with how we encroach upon the environment, particularly involving the animal-human interface. So let's just take a look at what we've experienced as a prototypic example. We had SARS in 2002, we had MERS in 2012, and now we have COVID-19 in 2019, 2020. It was the wet market interface where people come and do things that are traditional for them. They're not doing it in an evil way. This goes back hundreds of years. They go to the market and people bring in from the wilderness these exotic animals that have turned out to be delicacies that are served usually at festive dinners during feast days. People come, they intermingle, and that's when you get the jump of species. So if we could get sort of international regulations about animal-human interface, I mean, you can't completely stop that, but make sure there are some safeguards, some guidelines. The same thing with the evolution of influenza, where you see in certain countries, chickens cohabitating with pigs, people right next to them, and wild waterfowl who carry influenza. I mean, it's a time bomb for the evolution of new diseases.
Well, having been in the air 180 days a year prior to February of this particular year and living mainly across the world, not sitting at those tables for a while has been sort of a delicacy to me. I've been at a lot of those tables and not having to worry about those transmitted diseases. But once again, when the borders start to open up, I'd like to actually ask you that question about borders. Do you have any idea when Europe, America, and other borders will be able to get back to normal life? Do you think it's going to be pre-vaccine or post-vaccine? And if so, I'll ask you this: where's the first country you're going to go
to? You know, right? That's a great question, Dr. Holladay. You know, I really have had so much travel, like I'm sure you have, that I'm not very enthusiastic. I really am looking more forward to going to a restaurant or my favorite bar and having a hamburger and a beer before I make the next step to get on a plane and go somewhere. But, you know, what you were alluding to earlier, I think that gradually we'll be opening up countries. It is not only a public health issue, it also is an economic issue. Because if we don't let people in from European countries that are part of the international economic links between countries, it's going to have an even great effect on the economy, much less people who like to travel to Italy because it's a great place. You know, there's a lot of exchange commercially there that we really want to get back to normal. I think when we get a vaccine, which I believe, and I'm cautiously optimistic, that we are getting close to that. We now have 4 candidate vaccines that are in phase 3 trial. Preliminary data from the phase 1 suggest that it's able to induce the kind of response that you would predict would be protective. You never know whether a vaccine is going to work until you put it through an appropriate trial, but we're cautiously optimistic that we will have 1 or more effective vaccines.
Well, we're going to start to wrap this conversation up, and I want to ask you a little bit about yourself, because you've been such an incredible navigator for this pandemic for all of us, and I want to thank you for being that scientific voice of reason. But as you probably are aware, not just within our profession in laboratory medicine, we have 100,000 members in our own organization. There's a massive issue of burnout. In fact, it's rampant in our field, but it's also rampant throughout all of medicine right now. How are you dealing with burnout? How has it impacted you, your relationships? I know you have a very tight-knit family. What do you tell your wife and your daughters how to deal with stress, and how are you dealing with stress day to day?
You know, I deal with it, Dr. Holladay, because the issue I'm dealing with is so important that it energizes me almost too much. You know, you go to bed at night and you're looking up at the ceiling and you're dead tired because you're only getting, you know, I was getting 3 or 4 hours sleep. Now at the demand of my caring wife, I get 5 to 6, which is still not enough. You know, you stare at the ceiling and your mind is going a mile a minute about the things you need to do the next day. You know, burnout's not an option. You know, I understand how it can happen, but it can't be an option. There's too many things at stake. You know, my chosen profession as a physician, a scientist, and as someone who deals with serious outbreaks like this, I can't burn out. I just won't. It's just a matter of when it's all over, maybe I could kick my shoes up and lie back and get a good night's sleep for once, but that's not in the cards right now. There's too many things going on.
Well, in your prediction, are we over at least 50%? Are we closer to the goal of having this conversation? Do you think we're on the 50-yard line?
You know, it's tough to say. It's going to be very highly dependent on 2 things. One is the efficacy of a vaccine together with if people take the vaccine, because there's such a disturbing degree of anti-vax or mistrust in the vaccine because the government is involved with that. We got to get a safe and effective vaccine. People have got to take the vaccine, and we need to continue a degree of public health practices. If we do those 3 things, I think we're well on our way to getting this behind us. But if we don't do that, this could be a long haul.
Serendipitously, you mentioned that yesterday, because we have to be preparing for the flu season, right? So I got my quadrivalent flu vaccine. My pharmacist, I asked him, I said, have you got the COVID vaccine ready for me next? I'm just joking with him.
Yeah.
And he goes, no, we don't have it, obviously. I said, well, yes, we know a little bit about that in our field. I said, well, but you're going to be one of the frontline workers to get this. He goes, I'm not taking it. So we have to get even our own professional colleagues past the dispirited misunderstandings, that is, that this attenuated vaccine will not create the issues, despite that there may have been some hiccups in some trials that, as was said today by Dr. Redfield at the congressional hearings, correct? You wouldn't give a vaccine. The FDA would, even the FDA commissioner said, wouldn't approve a vaccine unless it was safe for all of us and their own families. So the message needs to be clear in that public health perspective. And I appreciate you bringing that up, because the penetration of this vaccine is going to be imperative for normalcy to ever occur again.
Right. That absolutely, very good point. That's a concern to me. That's the reason why we've got to continue to be transparent in everything we do and to reach out to the community, particularly those who traditionally are mistrustful, such as the minority population, African Americans and Latinx, people who understandably are mistrustful because of the history of how they may have been mistreated from a medical standpoint.
Well, thank you again. Dr. Fauci, it has been an absolute honor to have you join us today and helping shed, at least illuminate on our profession and that of the public eyes, how together we are stronger and how together we will mitigate this crisis. Again, Dr. Fauci, it's been a pleasure, and we look forward to your continuing work and navigating and be the roar that we need. Help us get our voices heard.
Thank you very much, Dr. Holladay. I appreciate your having me here with you. It was enjoyable. I believe it will be helpful, and thank you for having me. Good luck.
Thank you. We can't thank you enough. It's been a pleasure having everyone here today. There's been so many questions, and I'm sorry I was not able to get to all of them from our member perspective. But before we sign off, remember this town hall has been recorded, and you can view it or share it with your colleagues at ascp.org/town hall. It's also available for CME or CMLE credits, so you can claim your credits at the same site. Thank you, everyone, for joining us today. And as Dr. Fauci said, please be safe.